today speaking on behavioral strategies to manage your sleep in a COVID-19 and racism pandemic. I'm really excited to welcome Carmela Alcantara. She's one of our associate professors here at Columbia. And then also our guest presenter, Natasha Williams, who's assistant professor at NYU Langone. So with that, it's my pleasure to turn over the mics to you both. Thank you.
Thank you so much, Tiffany, and good morning to everybody joining us from near and afar. Really delighted to present on behavioral strategies to manage your sleep health in a COVID-19 and racism pandemic. I want to just start by letting you know a little bit about me and my training, and then I'll let my dear friend and colleague, Dr. Williams, introduce herself. As Tiffany mentioned, I'm Carmela Alcantara. I'm an associate professor at Columbia School of Social Work. I'm a licensed clinical psychologist by training, and I also have expertise and training in social epidemiology and behavioral medicine. And in my research portfolio, I really have two aims. The first aim is to just describe broadly how social factors or what we call social determinants are linked to health, that albeit mental health, sleep, or cardiovascular health, particularly in racial and ethnic minority communities. And the second aim of my research is really to think critically and deeply and thoughtfully about how do you translate those epidemiological findings, typically, or observational findings, into interventions. And so really today's presentation reflects some of the ways in which myself and I think Dr. Williams would agree, we tried to really make sure that we have a solid understanding of social determinants and how they influence sleep and also health disparities, and then with an eye towards thinking about interventions as well. And with that, I'll let Dr. Williams introduce herself.
Good morning, everyone. Thank you so much for the introduction. As Tiffany said, I am an assistant professor in the NYU Grossman School of Medicine. My work also focuses on a better understanding of the determinants of health and how it impacts underserved communities, but also through the lens of justice and health equity, which is really essential in this particular moment in time in history. And so sleep is also integral to that conversation. And secondly, it is also about disseminating and translating evidence-based behavioral interventions. Primarily that work has focused in the arena of sleep, as well as cardiovascular disease, including type 2 diabetes and obesity. So thank you for having me, and I look forward to a very exciting conversation with you all.
Great, terrific. So this is a brief outline of what we'll talk about today. And really you can think about today's action, training, dialogue as split up into two pieces. The first half, we're going to do our best to really equip you and share with you what we know about sleep and how it's essential to human functioning, provide you with a broad overview of sleep disparities and its relationship to health disparities in the United States, dive in and then talk about COVID-19 and what do we know about the structural inequalities and realities of the COVID-19 pandemic, and then provide some data as to the effect of the COVID-19 pandemic and racism pandemic as community trauma and spillover effects onto people's mental health. And then we'll sort of, the second half will be really focused on stress and sleep health, and specifically ending with some concrete tips, behavioral lifestyle strategies to improve your sleep health and important considerations in this pandemic. And even though it's not an explicit goal here, and I'll just transition to share with you the objectives of the learning objectives of today's session, which are, and as many of you who signed up already know, the first is to understand the function of sleep and its relationship to health and health disparities in the United States, to understand the impact of stress, discrimination, and trauma on sleep health within the context of a confluence of pandemics, the COVID-19 and racism pandemic, and lastly, to understand evidence-based behavioral strategies to improve sleep health. What's not here that I love that Dr. Williams actually referred to at the outset is that I think one of our goals is to, one, hopefully by the end of this talk, you're thinking differently about your own sleep health or your patients' or clients' sleep health, or the people you love and their sleep health. And then secondly, that you're thinking about sleep as a social justice issue. I mean, that's really sort of firmly what should be evident from today's presentation, is that we see sleep health as a social justice and also human right. And so we want to begin with a poll here, and I think Tiffany's going to help us out. So get out, participate here interactively with us. We want to ask you just a couple of quick questions before we begin. The first question, and if you can complete the poll, is how many hours of sleep per night do you usually get? So if you can answer that, and I will participate there. I don't know if you can see my screen. And the second is, how has your sleep changed in light of the COVID-19 pandemic and racial justice uprisings? And we'll pause here, and I think Tiffany will come back on to give us the results of that poll shortly.
All right, going to close the poll out in about 10 more seconds. I see a couple more votes that are coming in. And then if there's anybody, first, I see someone saying I don't see the second poll. Right now, we just only have the first poll launched right now. So for question 1, that's the only one that's launched right now. And then for folks who may not be seeing the poll, you can feel free to comment, write your response into the chat box. Essentially, if you don't see a poll at all, it might be because of the version of your Zoom application. But I'm going to go ahead, I'm going to end the poll now and show the results. And then after when you let me know, then I will go ahead and launch the second poll.
This is terrific. I'm not sure if you guys could see this, but interestingly, so about 13% of you said that you're getting less than 5 hours of sleep a night. We're going to talk about what it means to get less than 5 hours. About 52% of you are saying you're getting between 5 to 7 hours of sleep. And then only about a third of you, so 35%, are getting 7 to 9 hours. And we have no one who's reporting more than 9 hours. And what you'll learn today, that actually the current guidelines, national guidelines, really recommend 7 hours of sleep or up. So it's sort of talked about as 7 and up, although there's variation in that, and Dr. Williams will talk about that in a bit. So again, to sort of emphasize, about 65% of you are getting what we would, as behavioral sleep experts, call insufficient sleep. And then Tiffany, do we have time to do the second poll, or will we come back to that? Okay, so here's the second poll, and if you can all take some time to answer. So if you're just tuning in, we are completing the poll for the second question, which is, how has your sleep changed in light of the COVID-19 pandemic and racial justice uprisings? And I think we'll be getting the results of that poll shortly.
Yeah, we still got quite a few votes coming in yet. So I'm going to give it about 10 more seconds, and then I'll end the poll and share the results. And then again, if anybody is not having if anybody's having a hard time, like where if their Zoom application has not been updated, you might not see the poll. So the options are: you have a hard time falling asleep, have a hard time staying asleep, you might find yourself restless at night, it's hard to stay still, you may feel restless at night, it's hard to quiet your thoughts, you're sleeping harder than you were before, you're more tired than usual, regardless of how much sleep you get, and then you also just, like, I haven't noticed any changes. So I'm going to go ahead and end this poll and share the results.
And thank you again for that. I don't know if everybody can see the results of the poll, but I will read them to you in the event that you can. We had 33% of people who said, I have a hard time falling asleep, 35% who say I have a hard time staying asleep, 27% who are saying I feel restless at night, it's hard to stay still, 39% who reported I feel restless at night, it's hard to quiet my thoughts, 16% that are saying I'm sleeping harder than I was before, I'm exhausted, 43%, I think that's the highest percentage, who are saying I am more tired than usual regardless of how much I've slept, and only 10% who said I haven't noticed any changes. So overall, what this tells us is that 90% of you, I would count myself included among those, and probably Dr. Williams would too, have experienced some direct changes to our sleep, and they appear to be related to sleep disturbances, so more restlessness, less like high quality sleep, et cetera. And we actually have data that we'll share with you today that actually validate some of your the experiences that you just shared with us there.
That is really great. Thank you so much for participating in that. And what that lets me know is that you all recognize how important sleep is and how integral it is to our overall health and well-being. It's an important part of our daily routine. It is estimated that we spend about 1/3 of our time sleeping. I recall working with a colleague a few years ago, and she had conducted focus groups with Latina women. And one of the themes in those focus groups was that sleep was sort of food for the soul. And I just really, I just appreciated those sentiments, and it resonated with me so much because it's really important to think about quality sleep, getting enough sleep, and how essential it is to survival, just as food and water. So without sleep, we really couldn't maintain many of the pathways and sort of purposes of the brain in general functioning, sort of learning, memory consolidation as well. Next slide. So we know that the brain, really, we have to think about the role of the brain as it relates to sleep. There are many different components of the brain that contribute to how well we sleep, the quality overall, the different stages of sleep. And it really begins with the hypothalamus. We all sort of remember this from our biology classes, learning about the role of how the hypothalamus is really the control center. And it really works with other components to really help us for sleep and arousal. The cerebral cortex is really key as well, because this has to do with processing information and memory consolidation, and the pineal gland, which produces melatonin. Melatonin is really essential. Some people even report using melatonin as a sleep aid. So melatonin is really essential for maintaining that deep quality sleep that many of us hope to experience. Next slide.
And so with that said, we know that actually sleep is actually this very complex as an essential neurophysiological state. It looks the same when you think about behaviorally. What does sleep look like in terms of like its phenotype the same across culture. So this is characterized by your eyes are closed. There's behavioral quiescence or stillness and perceptual disengagement. We know that sleep is associated with physiological and psychological restoration, and it's a fundamental attachment behavior, meaning that you sleep the most, have the highest quality sleep when you feel safe and secure, right? And we know that sleep cycles vary across the life course, and we'll talk about that shortly. We know from lots of research that sleep is important for memory consolidation, for learning, for rest, for restoration of brain and bodily functioning, and also for maintaining physiological functions that help us, that help our body function from day to day.
So this is the recommendations that Carmela had mentioned earlier in the talk. So these are the latest recommendations. This is from the National Sleep Foundation. In 2015, they issued these recommendations for infants all the way to older adults. And this was really the first time that a major sleep organization really took on this role, and they consolidated several hundred different papers, manuscripts, peer-reviewed manuscripts, meta-analyses to come up with these recommendations. So for adults, which is, I would imagine for most of you, you're working primarily with adults, the recommendation is really within this sort of 7 to 8 time period. But what we know, and as Carmela will share next, many individuals, at least in the United States and even globally, are unable to achieve that recommendation. And there are a variety of different components as to why that may be the case.
This is just one example of that. So when we think about those recommended guidelines, which would be applicable across cultures, what we know is that actually about, anywhere from 70 to percent to sort of 80%, only about 70 or 80% of the population would say that they're sleeping well or they're sleeping are obtaining restful sleep. At a global scale, and this is a bit of older data, but about 24% of people globally would report not sleeping well. This changes depending on the sleep metric that you're looking at, if you're talking about hours of sleep, if you're talking about restfulness of sleep, and that there is this between country variation. When we look specifically at the United States, we know that on average, if you look at the United States as a whole, about 1 in 3 US adults report sleeping less than 7 hours of sleep, which we in the sleep community would refer to as short sleep duration. Importantly, there's substantial geographic variation. So if you think about the United States, the same way that you would see geographic variation for health, various different health outcomes, you also see that for sleep. And this map actually represents variation at the county level. So this is differences in the percentage of adults who are reporting sleeping less than 7 hours by county in the United States, with the darker colors representing a higher prevalence of short sleep duration. And you see this clustering in what in the health literature might be referred to as like the stroke belt in particular. In New York, that geographic variation also holds within a state. If you look at the state of New York in particular, based on CDC data, about 38.1% of New York adults report sleeping less than 7 hours per night. And you do see that variation in the prevalence of short sleep duration within the state of New York as well.
So I am looking at some of the chats, and I'm thrilled that there's such a lively discussion about this. Hopefully we'll be able to address many of these comments as we get later into the presentation. So I wanted to share sort of where we are as it relates to different recommendations for sleep. And these recommendations actually, for the first time, were included in Healthy People's objectives. So for Healthy People 2020, we included sleep. And so many of us who are in the field of public health, we know that this was the first time and really unprecedented to see sleep being included, which is, really great. But we haven't made much progress. This is sort of the mid-year report. So it is about a couple of years outdated now, actually, because we're sort of in the phase of thinking about the next Healthy People iteration. But we didn't make much progress in terms of meeting these different targets as it related to the number of adults who are screened for obstructive sleep apnea, and especially the areas as it relates to students getting sufficient sleep, as well as motor vehicle accidents. So we still have a lot of work to do. The CDC and other federal agencies really took this on, and they received tremendous feedback from the sleep community. And so hopefully, and I believe that in the next iteration of Healthy People, we will also still include sleep as we all work tirelessly to make sure that everyone really experiences sufficient sleep.
And I just sort of want to amplify that if you see here, this red box is indicating that it's getting worse. And so this was based back in 2014 when it was that mid-course evaluation about adults getting sufficient sleep. And, that moving in the wrong direction in light of the current pandemics, you can imagine that this, and we'll show you data to show that this is actually definitely, the pandemics are influencing those data and likely still continuing to get worse. So then what might be contributing? We just showed you these national, hopefully convincing data about the importance of sleep from a physiological perspective and a rest and restoration perspective. And so, and that the fact that there are guidelines that are pretty clear in terms of how much sleep you need. And the truth is that people have different beliefs about the importance of sleep. So on one hand, people might think that sleep is a luxury that's optional, particularly in a 24-hour society where sleep loss is really perceived as, or sleep deprivation is perceived as a status symbol. And on the other hand, those who might have cultural beliefs that sleep is a necessity and a biological drive for the reasons that we gave. We know though, however, that it's not that simple, right? You can have a belief that cultural that sleep is a cultural belief that sleep is a necessity, and yet not be able to enact or implement that belief because of structural constraints. And these structural constraints include things like poverty, holding multiple jobs that require you to commute potentially, and that require you or separately to commute long distances, or neighborhood factors like noise in the communities in which you live, or exposure to light, or financial stress and other stressors that might keep you up at night. But it is important to know that sometimes that these cultural beliefs do affect behavior, and then the structural constraints that impact whether someone's able to act upon those behaviors as well. There's a lot of really high quality and well substantiated research to show that sleep disturbances are associated with increased risk of cardiovascular disease, obesity, diabetes, cancer, mortality, and depression. We know that sleep disturbances are also associated with increased work absenteeism, so people are less likely to be more productive, to go to work, and that sleep disturbances are often undertreated in part because of some of the cultural beliefs that we just talked about before. In addition to the public health burden associated with sleep disturbances, we know that sleep loss and disturbances have been linked to several different accidents, particularly in the United States. Most recently and relevant to the New York area is the Metro North derailment that occurred in 2013, where I believe 4 people died and close to 60 were injured. And it was found later that the conductor of that Metro North train had undiagnosed sleep apnea and actually fell asleep while driving the train. Other accidents that have been associated with sleep loss include the Exxon Valdez oil spill and then the 3 Mile nuclear accident back in 1973. So with sleep disparities, so we just sort of gave you an overview about the importance of sleep. We now want to turn your attention to what we know about sleep disparities. And what we know actually is that the distribution of these sleep disturbances is not the same across racial ethnic groups. And so what I'm showing you here is a table from a review that actually Dr. Williams and I had the pleasure of co-writing together that shows that that was a comprehensive systematic review that compared and examined deeply what do we know about differences between different racial ethnic groups in comparison to non-Hispanic whites. And what we found is that for the most part, for most racial ethnic groups, particularly when it comes to sleep duration, that Asian, Black, Latinx, Native Hawaiian, and Pacific Islander adults research shows were had lower or shorter sleep durations compared to non-Hispanic whites. And this trend seems to hold for sleep quality. There are some mixed results when it comes to sleepiness and sleep complaints, depending on the specific ethnic group. But by and large, that when it comes to sleep duration, racial ethnic minority groups are sleeping less. There's really very little research that has focused on understanding American Indian and Alaska Native sleep, particularly in comparison to non-Latinx white populations. And one study showed that American Indian and Alaska Native adults actually had higher sleep durations. And even though this isn't a topic of our conversation, but we know that sleeping too little is not good for you, and actually sleeping too long is also not good for your overall health. And that's what we would call long sleep duration, sleeping more than 9 hours, for example. So an example of this, just to give it a little bit more nuance, this comes from the multi-ethnic study of atherosclerosis, focusing on 3 different sleep outcomes: severe sleep disordered breathing, or you might know as, or could think about as obstructive sleep apnea, sleeping less than 6 hours, and insomnia. And just what this graph shows is what we talked about before, that non-Hispanic or Latinx whites, who are represented here in blue, particularly if you look at sleep duration, they have lower percentage of non-Hispanic whites report or have less than 6 hours of sleep in comparison to racial ethnic minorities. And this trend seems to hold true we have sleep apnea here. For insomnia, it's a little bit mixed, although you do see a slight higher prevalence among Black and Latino adults comparison to non-Hispanic whites.
So here I wanted to present this slide really because it was published prior to 2000, and really before the different sleep stages were changed or renamed. But essentially what this demonstrated, it was a small sample size, so I should mention that as well. It was an in-lab study, which was a strength, but it also really just demonstrated that there was less deep sleep, particularly for African-American males and females as it relates to other racial and ethnic groups. And the reason why, again, I like to demonstrate this slide is because it shows sleep architecture. It was done in lab, and it was done for several years before we started to really think deeply and comprehensively about sleep disparities. So this is one of those earlier works that I think has made an important contribution to what we began to uncover as it relates to sleep disparities. Next slide. So this work was done by our colleague, Michael Grander. It was done a couple of years ago. And he used a behavioral risk factor surveillance system data among non-institutionalized US adults. And what was interesting about this study is, again, it looked at several different demographic factors as it relates to just even the overall perception of not getting enough rest or sleep. So while we rely on objective measures, we would like to rely on objective measures for sleep duration, the subjective reports of how an individual feels, how they perceive their overall sleep quality is just as important. And some studies, in fact, will demonstrate that that perception is probably even more so important, especially as we start to think about certain disorders such as insomnia, which we'll talk about later. Next slide. So this was work that Dr. John Louis and myself and others conducted a few years ago. We used the National Health Interview Survey. So this is a self-report, but we know that self-report does corroborate well with objective measures in certain cases, not all, of course. But short sleep duration was consistently reported by African Americans or Blacks as compared to whites. So why I like to bring up this study is because I would like to demonstrate that though we have talked about sleep health disparities for quite some time, it is important that we were able to uncover that these disparities were consistent for over 3 decades in which the data was available. We also used the behavioral risk factor surveillance study for this particular analyses as well. I recognize that this was really a large sample size, although we did limit the population to individuals who identified their race and ethnicity as Black or white, non-Hispanic whites. But for this study, we did look at the role of race and ethnicity and also found that that did contribute to reports of short sleep duration. And that was the main outcome in that particular study.
And so interesting, we're just talking about sleep disparities. I want to take a moment to acknowledge that, this isn't the focus of today's presentation, but that racial and ethnic and socioeconomic disparities in cardiovascular health risk behaviors, cardiometabolic factors, and disease have been well established, where racial ethnic minorities and those with lower socioeconomic status have worse health outcomes than their socioeconomic counterparts, high SES counterparts, and non-Hispanic whites. There's been some really recent work that's providing additional evidence that sleep may actually be a mechanism through which cardiovascular health disparities arise. And I just want to share with you the results of one study that was conducted here with colleagues in the medical school, where they followed. What we did is that these were adults who were hospitalized for an acute coronary syndrome. So think about a heart attack. They came into the hospital, they were discharged and followed a year later. And what this here shows, these are survival curves, and this is time to another major adverse cardiovascular event, and this includes death. And what we did was compare Black and white adults in the sample and to separate them out by those who were getting those 7 hours. Remember that cutoff is 7, so 7 hours of sleep a night or less. And what we found was that actually Black adults who slept less than 7 hours had the greatest risk for having a recurrent major adverse cardiovascular event. And this was not and this was very different and statistically different from whites from whites overall, regardless of how many hours of sleep they had, and also for Black adults who did report sleeping 7 hours of sleep or more a month after the release from the hospitalization. So this, again, this is that sort of a closer link to the role of sleep in explaining cardiovascular health outcomes.
This is really important because, as Carmela said, many are trying to sort of unravel these different disparities, but also understand the interconnectedness with health disparities overall, particularly among Black and Latinx populations. So this particular study is from the Jackson Heart Study. In this sample, there are African Americans or Blacks in Jackson, Mississippi. And for this analysis, which is still currently under review, we looked at about 5,000 participants and we had longitudinal data. And we were interested in understanding the time to event for cardiovascular disease outcome. And so what we found though overall was that there was really poor sleep quality among the population. About a third or so reported poor sleep quality, and found that that was significantly associated with a report of cardiovascular disease over time. And that really just sort of, what we hope is that it will add to the discussion and our understanding of how sleep quality and duration continues to be significant risk factors for cardiovascular disease outcomes. And essentially developing interventions around sleep quality and sleep duration may be important for this population.
So with that, I think we're going to turn to talk a little bit about structural inequalities in COVID-19 pandemic.
So, this is a very challenging time for many of us. And we really want to shift the discussion from just really focusing on individual level factors, but also trying to better understand how these structural inequalities contribute to overall risk for COVID. You may have seen in the media, there's a lot of discussion around individual factors such as hygiene or hand washing, or even behaviors around use of masks. But there are significant structural factors that contribute long before some of those others may take place. Next slide. So one example, obviously, is thinking about our frontline workers. So we know the majority of our frontline workers are minority populations, underserved populations, and these frontline workers are also less likely to be insured and are underinsured as it relates to other different type of occupations, those who are in executive and leadership positions as well. So how could some of these frontline workers be at greater risk for developing something like COVID, and how that may impact their overall health and well-being must also be a part of the discussion as we think about COVID pandemic. Recently, the Centers for Disease Control reported they looked at a number of US workers across meat and poultry processing facilities. And again, this is a frontline staff because it's integral to our overall food supply. And so among approximately 130,000 workers, so they had a very large sample size, they looked at the number of cases of COVID and deaths. So this is really important because it demonstrated that these individuals are at risk, and there are a number of things that may happen in these facilities in which they work, in addition to some of their own issues, such as crowded living situations and transportation conditions. But again, these are beyond these individual level factors. These are multi-level factors that are contributing to the disparate outcomes that we see as it relates to the COVID pandemic. And next slide. We see this particular report is from a study that was done in California, and they looked at the overall financial stressors as well. So 61% of Latinos reported that they or someone in their household experienced a job or wage loss. And we know, as it relates to sleep, these financial stressors contribute to increased reports of poor sleep quality. So thinking about the financial stressors and how that contributes to significant sleep or poor sleep as well would be an important part of the conversation that we continue to have. And next slide.
And I just, before we proceed, I think it's helpful to sort of know, though we sort of didn't state it, but we know, and past research has shown, current research is showing that Black and Latinx communities are at greater risk of not just being exposed to the virus and contracting the virus, but also dying from the virus. And being able to acknowledge the structural factors that are related to that and separate them out from the individual level factors is timely. And I think particularly for those of us who are thinking about this as social justice issues, really essential to that work.
So we talk about racism and what is happening in the current pandemic. And one of the things that I want to mention too, as it relates to racism, there was a systematic review that was conducted several years ago, and by Natalie Slopin and David Williams, that demonstrated that discrimination, for sure perceived discrimination, to a lesser extent, racism contributes to poor sleep quality, sleep architecture, as well as sleep duration. So the evidence is there. We also know through several meta-analyses that racism contributes to cardiovascular disease outcomes, though the research is much stronger for mental health outcomes as well. There is still evidence of health outcomes. So it's important to think about this in these different buckets. It's sort of how I like to think about our understanding of racism, the structural, organized factors that contribute, the individual or perceived microaggressions, day-to-day reports that individuals may experience. And then also more recently, many researchers have started to look at the idea of reaction or anticipation, the idea of this heightened vigilance, and how that might contribute to adverse health outcomes as well. There's been early reports that this sense of reaction and anticipation contributes to obesity among Blacks and African Americans. So it is considered to be a stressor. The work by Chandra Ford, as an example, Carmela talks about the idea that racism is a public health issue. And we are seeing that unfold as we are also dealing with the COVID pandemic. So those are sort of, I think, the general umbrella way or broad way of thinking about how racism impacts individuals and society as a whole. And it's important to think about the structural factors as well.
Yeah, and related to that, thinking about how there's a structural and how structural racism affects health, and then these individual level factors that Dr. Williams described in its relationship to discrimination as a social stressor, and that hypervigilance and reaction anticipation as also a stressor that we know is harmful for health.
So, we can't really have this conversation without thinking about trauma and without thinking about informed strategies to address trauma in underserved communities. This is from SAMHSA, their Trauma and Justice Strategic Initiative, this definition of what individual trauma relates to, but there's also community trauma. And there have been many to demonstrate that thinking about racism, structural levels of racism, individual factors, is also a form of trauma. And so individuals, particularly underserved and vulnerable populations, we sort of find ourselves in this moment as we're thinking about the COVID pandemic, the loss of life in the United States with over 100,000 individuals. And that's a trauma in and of itself, but then also the daily experiences of traumatic events as it relates to policing, and as it relates to other individuals who are maybe described as white supremacists, and seeing those things and how it impacts an individual's mental, physical, social, and emotional well-being is important for us to recognize that as we begin to have these conversations, particularly also around healing for individuals and certain communities as well.
And I think that perspective of the pandemics, both the racism pandemic and the COVID pandemic, as a form of community trauma is really essential. And just to what Dr. Williams was discussing, there is data on the spillover effects of police killing and police brutality on the effects in BIPOC, and specifically here it's Black American communities. And so I won't go in detail about this, but I'll sort of try to share with you the highlight, and I encourage those of you who are interested in the data to take a look. But this included close to 39,000 adults from a public health surveillance study, and what they were interested in is understanding how exposure to a shooting in the 3 months of this psychosocial assessment that happens in this public health surveillance interview was associated with reports of poor mental health, and evaluating differences between Black adults and white adults, and specifically also wanting to understand the effect of just the number of killings and also any killing and whether the victim was armed or unarmed. And I just want to focus your attention on this oval here, where you see here in what they found in this national data set, US-based data set, was that when the victim was an unarmed Black American, you see that the mental health, there was a spillover effect for the mental health of Black Americans, and that they were reporting, worse mental health in comparison to their white Americans here. And this was, if it was, this took into account the number of killings or whether there was any killing of an unarmed Black American. So there's data that's corroborating, the effects of a racism pandemic, of police killings as a form of community trauma that's having a direct impact on Black communities. And we won't, I think the point of this is to really highlight that there is data, additional data beyond qualitative data that exists, and historical data that exists about the impact of structural racism and police killings on Black communities. There's additional national epidemiological data to support this as well. Now we're going to just turn our attention to what do we know about stress and sleep health, and then that will try to transition us to talk about, well, what can we do in light of the current extraordinary times that we're living in. In terms of stress and sleep health, we know from both lab-based or experimental research and also from community field-based research that psychosocial stress, whether it's acute stress or chronic stress, is associated with various different dimensions of sleep health, including duration and quality, to name a couple. And that Black, Indigenous, and people of color, like we just talked about, they face specific stressors that are associated with their marginalized status. And in the sleep research community, there's been substantial research now to show that exposure to ethnic discrimination is strongly associated with self-reported adverse sleep outcomes in racial ethnic minorities. And Dr. Williams referred to that systematic review from a couple of years ago. There's also other research that I've led showing that other forms of sociocultural stressors, like acculturation stress, which is the stress associated with adapting and to the U.S. mainland culture in Latinx adults, is associated with sleep disturbances like insomnia. So we have evidence that stress affects sleep, that sociocultural factors affect sleep. But interestingly, even though I was just talking about that direction of stress affecting sleep, we actually have research to show that your sleep the night before actually also affects the way that you appraise your stress levels. And these come from intensive longitudinal studies that have really lots of units of observation and that provide rich data in support of this. And I want to show you one study that is a result of that, and I think ties ties what I just shared about sociocultural stressors and sleep and the potential of sleep of actually helping you cope. And so this is from a study of over 200 racial ethnic minority adolescents. A study was published just last year. And what this showed is that actually the sleep the night before, so whether someone, and I'll just focus for our conversation on this top first graph here, because there's a lot here, but for those adolescents who reported high sleep duration the night before, the next day, when they measured their discrimination the next day and other kinds of coping behaviors, what it found is that those who had long sleep the night before and experienced high discrimination, they were able to exhibit greater problem solving skills. So sleep actually facilitated, more sleep duration facilitated coping in the context of this adverse sociocultural stressor like ethnic discrimination. So there's a lot of, this I think is one of the most exciting studies out there. Be curious to sort of see more work develop in this area. But again, it sort of goes back to why both Dr. Williams and I are very excited about the potential for sleep to help us cope and address some of these health disparities that we talked about at the outset. When we think about the COVID pandemic now and sleep, and what some in the behavioral sleep community, neurological community are referring to COVID-somnia, we know that the stark and swift disruption to our work and school routines had a major impact on our sleep schedules and resulting in delayed or irregular sleep schedule and patterns. The uncertainty and the stress resulting from the pandemic, the social isolation as a result of several different of the lockdown orders, coupled with the non-ending news consumption and news cycle, which only promotes rumination. And there's been other research to show that substance use among women apparently has been much higher during the pandemic, including alcohol use, which we actually know in terms of sleep, substance use close to bedtime is actually harmful, or it doesn't promote good sleep. So all these factors are creating this perfect storm to really result in what some are referring to as this COVID-somnia.
So I just wanted to share briefly this work that my colleague, Dr. Blanc did. She's at a postdoc at NYU Langone. And she looked at the 2010 earthquake in Haiti. And one of the things that she found was that there was subsequent experiences of sleep disturbance post the earthquake. So 94% reported insomnia symptoms, difficulty falling asleep or maintaining sleep. 43% reported having nightmares, and there was a significant positive correlation, as you would expect, between the experiences of sleep as well as symptoms of depression and post-traumatic stress disorder. And I raise this issue here because I think we're going to start to see, hopefully there will be more research that is done as it relates to sleep disturbance and the COVID pandemic. So this is from the earthquake, but the idea is that it is a similar type of traumatic event, or at least experienced as a traumatic event for many individuals and communities as well.
And taking that same logic and now thinking about what we know and the great work that was produced, and I want to sort of give a shout out to some colleagues here at the CUIMC Medical Center who during the peak of this first wave of the pandemic here in New York City, were able to survey New York City healthcare workers for their psychological distress during the COVID-19 pandemic. And what they found that really sort of extends Dr. Blank's work now thinking about our local context is that 71% of those New York City health workers reported symptoms of insomnia, which lends support to that COVID-somnia. 65% felt lonely, 57% had acute stress, 48% reported depressive symptoms, and 33% had anxiety. And I just we won't spend time on here because we're hopeful to get to what we can do about it, but just want to really highlight here that there was this variation in the level of psychological distress and type of psychological distress by healthcare worker type. So you see the highest levels observed among nurses and AP providers across the board, across for, acute stress disorder, depression, and anxiety.
So we have additional data that's starting to emerge, and this is from data from the UK, or 3 European countries, I should say. And this was an online survey, so I recognize that, but it included over 400 participants. They were primarily young. And interestingly, and we believe at least what the author stated, is that there was this improved individual sleep wake timing and more sleep. And what they suggest is that this was because of their schedule. So they're actually able to work from home, and that may have played a role. But there was also decreased quality, which you would expect that there would be some decreased quality in sleep. And remember, what we've tried to share, and others have demonstrated, is that the duration as well as the quality are important as it relates to overall daytime functioning and well-being. So I think it's interesting for us to really start to have other ideas about how to unpack some of this information that we're learning from the COVID pandemic and sleep disturbance, particularly among vulnerable populations. So we are going to talk about one of the most prevalent sleep disorders. Insomnia is the leading sleep disorder that's reported in the United States for sure, and globally. So people with insomnia, many of you mentioned this at the outset of the presentation, in terms of trouble falling asleep, staying asleep, or both. And it's also important that there is this sense of daytime impairment, or your ability to just not function as well as you would like. And so it is really prevalent. And one thing to keep in mind, though, a lot of individuals are experiencing acute insomnia or short-term, and it will be far less that will actually report chronic insomnia, long-term insomnia that they may experience for 3 months or longer. So I guess one of the things that we'll share in our different strategies and tips is that if you are experiencing some of this, there are things that you can do to improve the quality of your sleep. So generally, we know some of the risk factors for individuals who experience insomnia. Experiencing a traumatic event for sure is definitely one of those risk factors, but also depression. There's really this bidirectional relationship between depression and insomnia as well. Females tend to report more insomnia, older adults do as well, and other stressors such as lower income, and individuals who have other sleep disorders such as obstructive sleep apnea. So thinking about traumatic events, demographic factors, the results are sort of, I would say, mixed based on the review that Carmela and our colleagues conducted previously. The results are sort of mixed as it relates to insomnia, but these are the general risk factors that we think about for those individuals who report insomnia symptoms.
Yeah, I probably just want to add here, which Dr. Williams mentioned earlier, but something bad happening in your life, like the death of a loved one, in the context of COVID, we know that there's been a lot of loss and unexpected loss and disruptions to the way that, typical grieving practices. And so, you can almost project that, I think that it sort of, lends credibility to this increased focus on COVID insomnia, and potentially I think forecasting onto the effect of these losses on insomnia. We know that it is a risk factor during non-pandemic times as well. So we're going to turn our attention with and hopefully close out and then open up to some questions, but turn our attention to various different evidence-based behavioral strategies to improve your sleep. We know that there's evidence to support different kinds of treatments to manage sleep problems, including pharmacological or medication-based interventions. So, there's concerns there about side effects there's concern for side effects, and also growing dependent on medications is a big concern as well. There are behavioral treatment options, like various different kinds of psychotherapy options, which we'll talk about here, and also lifestyle changes, which you can think about related to sleep hygiene or educational sleep education kind programs that or treatments that are really emphasizing what you could do to improve your sleep. And that's what we'll end up talking about both today. This is just a list of different kinds of behavioral, effective behavioral interventions for treating sleep problems. This is not necessarily an exhaustive list, but it is a list from research that we know. And these includes various different types of behavioral therapies that might focus on sleep restriction, stimulus control, or sleep hygiene, like we talked about, mindfulness-based stress reduction. There's motivational enhancement with CPAP, and also cognitive behavioral therapy for insomnia. Most of the trials for these interventions have been conducted in primarily non-Latinx white communities. And so there is a lot that we don't know, but some really exciting work to translate and adapt these interventions for Black, Indigenous, and people of color.
Okay, thank you. I just want to acknowledge, I sort of peeked over at the chat again and see some great questions. One is about, which we'll get to, but I want to make sure we do, how do new moms survive with very little sleep? And also someone stated they think it's difficult to distinguish between COVID-somnia and racism-somnia. I didn't think about that. Really great point. So how does behavioral therapy work? I would imagine with our audience that many of you may have knowledge of this information. But one thing I have to share, I should take a step back and say, first, for an individual to get to behavioral therapy, there are a few things that are needed. Obviously, it's access to healthcare. And that healthcare would need to include some sort of behavioral therapist or mental health provider. And so those are just two important structural factors for us to think about. Another factor that's important to consider before we get to behavioral therapy is whether or not the individual or patient is going to discuss their issues of sleep with a healthcare provider. And we find among minority populations that is less likely to happen. And also vice versa, whether or not a provider is going to ask an individual about their sleep. And by and large, it does not happen, despite the fact with some studies showing that as many as 90% of patients report experience some form of sleep disturbance. So we have a lot of work to do. So behavioral therapy, if you find challenges in terms of access, there are self-help books. There are some limited research to suggest that self-help books can be effective, depending really on, I would say, the chronicity as well as severity of whatever the sleep problem is. And one other thing that I want to mention generally, before behavioral therapy is available or prescribed, if you will, an individual will need to see their healthcare provider. So there's one-on-one with an insomnia expert, and Carmela will share or has shared in her work just the overall limitations in terms of access to behavioral sleep medicine providers. So there's increasing number of different platforms for virtual coaching and self-guided with digital therapeutic work as well that may be effective depending on individuals' needs and their overall desires that they may have for sleep.
I won't spend a lot of time, but just wanted to acknowledge that this digital therapeutic space has really had a boom here with respect to insomnia. There's several different options with really good evidence to support these self-guided, even mobile platforms for treating sleep issues. And these are some that are here. By no means is this an endorsement of anyone in particular, but just in terms of understanding that really the behavioral sleep community is thinking creatively about expanding expanding access for getting high quality evidence, high quality treatment for insomnia in particular.
So this is actually something that I put together. I was sort of thinking about a way to really just articulate what behavioral therapy would look like, particularly maybe for low-income communities, individuals that may have challenges with health literacy, and just trying to make it as very simple as possible without sort of the jargon. So we know, at least for an individual that reports insomnia, their provider is going to try to want to understand what is causing the insomnia and what is related to their general sleep habits and their general sleep routine. So an individual should expect, depending on the provider, hopefully you have a great provider, that they're going to collect some baseline data to get a sense of what your sleep looks like. And they'll monitor that generally for about 14 days. That's sort of the standard. But then there are just these key recommendations once an individual starts with the behavioral therapy. And it's all about routine. We'll talk about some of these as it relates to sleep hygiene tips. But you're going to need to go to bed and wake up the same time every day. You want to spend no more than 20 minutes or so if you can't sleep in bed. It's recommended that you get out of bed and do some other relaxing activity. It's recommended that you avoid taking naps during the day, just so that you can build up that homeostatic drive for sleep at night. And again, I mentioned this idea about a sleep diary, so a way to document what your sleep looks like and how it's improving over time. Very similar to maybe like a food log is another comparison. And then I described you have to meet with this insomnia expert. Generally 4 to 6 sessions is about standard, but it can be longer depending on the severity of an individual's sleep experience, or sleep disturbance, I should say. And next slide. So, quickly again, thinking about a particular audience that I was working with at the time, I came up with a list of, just pros and cons. And this is an exercise that people need to consider as they're thinking about behavioral therapy. What are the pros and cons? Your sleep will absolutely improve. Sort of the major con for many individuals is that it just takes a long time. And at least within the first 2 weeks or so, it can be really challenging for people to stick with that schedule, to avoid taking naps and so forth. But the good news is that it is effective. And I have another slide that talks about that as well. So specifically thinking about cognitive behavioral therapy for insomnia, or CBTI, again, for individuals that received a diagnosis from a provider of chronic insomnia, CBTI is an effective evidence-based behavioral therapy, so much so that the American College of Physicians recommends that CBTI is sort of the first line of therapy. This is supported by the major behavioral sleep medicine organizations as well. The clinical gains relate to the ability for their overall total sleep time, not so much, but in terms of their wake after sleep onset. So how much sleep disturbance do they have at night tends to improve over time. And I list some of the different major components that's involved in these different sessions. So it is a multi-component therapy that includes sleep restriction, cognitive restriction, the idea that, hey, it's going to be another night where I'm not going to be able to fall asleep. No matter what I do, I can't sleep. Those are just some of the common reports that individuals may have that are addressed in therapy. And I'll leave it there at Carmela with this slide.
Yeah, one thing I just sort of would say is that while this is describing a standard CBTI package, there is some really great evidence to show that even a single shot of or brief CBTI also seems to have some important effects. And I think that's a really interesting model to sort of to think about, and just want to make sure to acknowledge in today's talk for those of you who might be interested in some follow-up about that.
great point, especially for those who are considered about time.
Yeah, yeah.
So we didn't spend a lot of time talking about pharmacotherapy, but it is an option for individuals. And one thing that's always recommended when you're thinking about treatment for yourself and or clients that you may work with is this values clarification exercise and thinking about how do you make a decision. So do you want to get relief right away? If that is an important value for you as it relates to treatment, then behavioral therapy might not be your first choice. If you are concerned about developing dependency on different medications, then obviously behavioral therapy would be the sort of first line of treatment options for you. And then also within the context of our vulnerable, underserved populations that are paying bills and rent and these other financial stressors, we have to also think about the affordability as well.
Thanks for that. And the list of questions will be a part of our slide deck for those of you who are interested. Now we're going to turn our attention to talk a little bit about sort of sleep hygiene 101 or sleep education 101 and sort of end with some key concepts and tips that are part of a standard sleep education program.
Great. So these are sort of classic sleep hygiene tips and recommendations. And one thing that I think is important for us to think about in this current environment, usually these are very individualized, but I think for many of you that may be juggling family and other close individuals in your networks, is to really think about how this is sort of a family approach. So it's important for you to keep on a sleep schedule as well as for your family. So whether it's an older adult that you're caring for, if you have little ones at home, ideally everyone is going to be on a sleep schedule. And the extent to which that you can all be consistent with that sleep schedule will make a significant difference in your time, in your sleep quality. It's recommended that we get plenty of bright light during the day. I know, especially early on in the shutdown, at least in New York City, that may have been enormously difficult for individuals, but the extent to which you can get out and get bright light will make a significant impact. And then also avoiding the bright light at night, because that bright light is sending signals to our brain, to our pineal gland, to let us know that we should stay awake, even though it's time that we should be sleeping.
I'll just add before we go to the next slide that this keeping, often when I do community or public health community talks, keeping that consistent schedule is the one that always people sort of talk about. I don't know that I can wake up, I wake up at 6 during the weekdays. I want to sort of sleep in on the weekends. That seems so hard, but really that consistency just helps your internal clock, your body get really accustomed to when it's wake time and when it's sleep time, and really promote that biological drive and need for sleep. So I just wanted to underscore that.
Awesome. So similarly, a few more of these well-known strategies is to avoid caffeine at bedtime. Caffeine signals our brain that we should be awake. And if you're like myself, you get lots of caffeine to get yourself going during the day. And one of the strategies that I use is I have a cutoff time for when I stop drinking caffeine. And I would just recommend that, the recommendation is 6 hours or longer, as long as how long it stays in the system. So it's important for you to factor that in. Nicotine also contributes to our inability to fall asleep, and avoid alcohol as well. So we know, yes, alcohol is a depressant, but alcohol also is a disruptor, and that it disrupts our sleep. So people are less able to maintain refreshed sleep and to stay asleep without waking up in the middle of the night.
Yeah, and this is also one of, when it comes to avoiding alcohol near bedtime, when I talk to community members, that often comes up because they'll report back, well, I use it to help me cope and get to sleep, and then realizing and sort of doing some psychoeducation that, yeah, sure, it might help because it is a depressant, might help you fall asleep, but just as Dr. Williams said, it will make it harder for you to stay asleep. It has that rebound effect in the middle of the night.
So lastly, this is about, I'm going to just share here, be candid. This is one of the challenges that I have with these sleep hygiene tips, is that it automatically assumes that we all individuals have control over these things. Many people do not, but the idea is that you should keep your room at a cool temperature. So if you're in a rental apartment, that makes it very difficult. But if there are other things that you can do, such as your linens and what you go to bed in at night wearing, could make a difference. But the idea is to keep a room temperature cool setting. I mentioned limiting the naps because, again, the idea is that you want to build up that homeostatic drive. So at night when you're ready to fall asleep, you're able to do so where it's not going to take you, 30 minutes or longer to fall asleep. Exercise is key. Obviously, it helps with our ability to stay asleep during the night. So it's important to get exercise earlier during the day. And also it's recommended that we keep our bed, this is from Dick Bootson's work, we keep our bed for sleep and sex only. So limit reading, television watching, being on our iPads and other devices. I shouldn't just, I don't want to promote iPads, but any device during night in the bedroom with you is recommended to avoid that.
I'll just add 2 points to what Dr. Williams said in terms of exercise, because this is a question that comes up. We actually tried in sleep education, the recommendation is that you're exercising and you don't want to exercise really close to bedtime. So sometimes people are like, oh, I'm going to tire my body out. I'm going to exercise an hour before bed and then go to sleep. Actually, the recommendation is you don't want to do it too close to bedtime. At least reserve 2 hours between when you exercise and when you're going to go to bed if you are going to exercise in the evening. And there's been research to show that actually for sleep, exercising in the morning might actually be better and promote better sleep as well. So I think that's and then no hanging out in the bed. That's the, the strictest form. And we actually know that it works in terms of making sure you preserve your bed as only for sleep and sex, as Dr. Williams talked about. Just want to add a couple of additional sleep hygiene tips that were mentioned earlier, but just want to come back to it and emphasize it. If you're in bed and you're unable to sleep, it's really important to get up and get out of bed, because you really want to train your body that your bed is the place. Your conditioning, really, it goes back to these conditioning principles and conditioning your body that your bed is only for those 2 activities. So no, you don't want to hang out there when you're not sleeping, because it'll work against promoting and conditioning your body that your bed is for sleep. So if that's the case, if you're not able to sleep, if it's been 20 or 30 minutes, try going into another room until you feel tired again before returning to sleep, and then repeating this process as necessary, because what you don't want to do is create a pattern that your bed is where you stay and you're lying awake. It's going against the ideal function, which is that the bed is providing a place for you to sleep. The second important additional tip is to establish a buffer zone, or even I would sort of take that further to think about a routine. So set aside some quiet time before bed to spend doing enjoyable activities that will help you to feel calm and relaxed. We do this for those. I think there was a question about a new mom and routines, which makes me think about with children, how you really have to, you teach them. It's a skill that they learn to be able to fall asleep by themselves. And part of that is creating a routine. And as adults, we lose that sometimes along the way and during times of stress. So just emphasizing again, the importance of creating a wind down routine and having this buffer zone between when your activities end for the day and then hopping into bed and then creating that bit of buffer. And the last additional tip to include here is try not to worry while in bed. We realize that's easier said than done. But if you're planning, feeling anxious, or having racing thoughts, again, those are activating activities. You want to get up out of bed, ideally until these mental activities are no longer preventing you from falling asleep. There's been some writing that if you want to have a book or somewhere where you're going to journal about your worry, not in your bed, not in your room, but sort of get up and do that in a separate space if you're able to, and write those down and then come back to bed so that you're not bringing it into your bed, and you're preserving, again, that conditioning, maintaining that your bed is for sleep or sex only. And I think one of the most important tips when it comes to sleep, and for those of you who have kids, you might understand this because I try to remind myself of this during nap time, is, you don't try too hard to sleep the same way you can't really force your kids to sleep for nap time. And instead, you really have to let sleep unfold. And it's true, what we can do and what we're trying to do is really equip you with different strategies that provide ideal conditions for you to be able to sleep, or better conditions. But again, you can't force the outcome of sleep. And just wanted to share some additional guidelines that came out from the behavioral sleep medicine group. And these are strategies for managing acute insomnia during COVID-19. This is emphasizing some of the very points we talked about earlier, including detecting, which is tracking your sleep with a sleep diary. If you're feeling like, okay, I think my insomnia is coming back, being able to track it. And there's a fine balance because people with insomnia are more likely to be really interested in the data. So it's a fine balance between detecting it and using it to provide data, and then I think becoming obsessed over the data. The second point is to detach. So we talked about this, but avoiding bedroom activities, get out of the bed when you're not sleeping, and trying to really preserve your bedroom as a place for sleep or for sex, or preserving the bed in particular as that place. Use distraction, which is practice cognitive control and imagery distraction techniques. And this is, again, going towards, how are you going to manage some of the distress associated with insomnia. It's importantly too, based on these recommendations, particularly for practitioners, if you're working with clients or patients who are reporting this acute insomnia, to assess for maladaptive coping strategies. We talked about the increase in substance use in the context of COVID and alcohol in particular, and then to think about how you can enhance resources for coping for patients or yourselves with recurrent daytime stressors. So this could be enlisting, social support, or helping patients, clients, or yourselves to think about how you can enlist additional social support to help you cope with the current stressors, or behavioral activation to help you cope with the current stressors.
One thing that I just want to share here also, as we're talking about chronic and acute, is that less than 5% of individuals who experience acute insomnia will go on to develop chronic insomnia. So I think that is very hopeful as we're thinking about how we're managing our sleep during this time, that we don't necessarily want to think that it's going to be a long-term or permanent type of issue that we're starting to deal with now.
Thanks for that. And then some additional sleep recommendations, not necessarily thinking about insomnia, but just in general for those of you looking to improve your sleep in the context of COVID. Reestablishing exercise, meals, socialization routines are really important. Just we talked about how, the lockdowns in particular and the shift to remote work really upended those routines, and that had an impact on sleep and regularity. If you are having nightmares, practicing deep breathing or other relaxation techniques after waking from nightmares. Limiting triggers, news consumption can be a big trigger. We've talked about this. This has been, I think, mental health experts have been recommending this a lot. So think about how you can limit how much news you're consuming. For parents with children and adolescents, it's important to prioritize activities that build that sleep need that Dr. Williams talked about. So this means ensuring outdoor activity, that exposure to bright light that was talked about before, and then discouraging the sleep disruption like screen time, additional napping during the day, particularly if it's not recommended during that set developmental period. And then importantly, prioritizing bright light exposure in the day. So this is, if you're able to get out 30 to 60 minutes after waking, again, that's a really practical strategy to help your body promote that homeostatic drive for sleep, that build up that sleep need. And then in turn, you want to avoid the bright light at night. So they're sort of working, and the bright light is activating. And so you want to get that bright light during the day, not at night if possible. And so we have some concluding questions here, but I realize, we're almost out of time and we have lots of questions in the Q&A. So maybe we'll stop We'll leave this concluding questions up here and then maybe start taking some questions from the Q&A, if that works. And thank you all for hanging in with us. I see that we still have about 321 people. Okay, let's, Tiffany, shall I just go ahead and ask them, or will you be able to help us here?
Whatever you prefer. I'm definitely available here to ask. Also, though, too, if there's some that you see that you really want to make sure you prioritize and get to, I want to respect that as well. One thing I do want to actually do lead out with is that we have from Edgar asking what is considered poor mental health, and this is from slide 34 with the figure 2 diagram study.
Sorry about that. I was on mute. Can you ask that question again?
Yep. So going back to, it's from slide 34, I believe, and it's from Edgar, and he was asking what is considered poor mental health as referenced in that on that slide.
Yeah, so this was in that public health surveillance scale. I think they asked people the number of days that they would report like poor mental health. So it's really it's not a diagnostic question. It was trying to get a sense of people's quality of life and whether they had perceived their mental health to have gotten worse or better.
It's from, that study used data from the behavioral risk factor surveillance system.
Okay. All right, and then we also have another question regarding naps. And so do naps count towards total hours of sleep? And then should American companies be encouraging napping?
It's interesting because there's some cultural global variation with regard to napping. So I think it's important to acknowledge that there's some cultures where napping is really encouraged and part of daily practices. From the literature here in the United States, and particularly for adults who are suffering from sleep problems or at higher risk for having sleep problems, we really discourage naps because it works against building that sleep drive. If people are wanting or feeling that they need to take a nap, the recommendations typically are, are you able to get a nap in that's 20 minutes or less? Dr. Williams, would you add more to that?
I was just thinking about the siestas as it relates to napping and cultural differences, but I think the key also is to always ask, what do you mean by nap? Because that 20 minutes is so key. And in certain communities, a nap is an hour. We know that that's not a nap. So it really depends on what we mean by napping.
All right, and then just kind of following up with the cultural element, we had a separate question, and that was asking, like, is there a cultural element valuing like getting up early and factoring in these cultures as well? In other words, if a culture promotes getting up early, for example, to not waste a day, can that influence how many hours of sleep they get? And then within that, I'm just going to also add, then, like, how do you work with your clients around that in respect to their culture, but if you also are seeing that their sleep is being negatively impacted?
I think it's really important to partner with your clients when it comes to understanding cultural beliefs and how they're affecting behavior, and to be able to do some kind of functional analysis to be able to evaluate, does it work or not? I know that the question, and I can't see it now, but one of the questions was, getting up early. Like we said, actually exposure to bright light is good. So that's a good, I think that's probably a good thing. It depends like how long the day is on the back end. And it really is that like functional analysis, understanding a client's constraints and understanding what they are able to have an impact on. But often I think sleep health, or historically sleep health, has been in some ways devalued. And so that's, I think, has been to a detriment. And there's, in the last several decades, like Dr. Williams had talked about, really an emphasis on recognizing sleep as a really important public health issue. But it is, I think, whenever you're talking about clients across cultural differences, really understanding their cultural beliefs and positionality and their own constraints, and helping do functional analysis of what is and what isn't working. I've also found that, particularly working with Latinx communities or talking with Latinx communities, that you know, there, some of the, and particularly women who I spoke to, would be interested in improving their sleep or helping their children get better sleep. So thinking about it as this intergenerational effects, and where are they able to help their children then improve their sleep if they're not so much able to improve their sleep along all of these different dimensions that we talked about.
Okay, thank you.
Add one thing is that oftentimes when people see the connection with sleep and health, they start to recognize the importance of making changes if necessary to their sleep. So thinking about how does it relate to their overall health as well as work productivity too.
A question that came in that I think is also just very helpful for framing this for other folks who have this as well is, can you just please define Latinx? As that is a term that's come up repeatedly throughout the presentation.
Yeah, so the shift to use Latinx is really a way of acknowledging that and moving away from a gender binary that's only including and really in some ways embedded in the Spanish language, that's only acknowledging either male or female. And so Latinx, and you might see it in different ways, might be A or O, Latino, A, backslash or / and then X. So it's a way really thinking, trying to use the most inclusive language that moves us away from the gender binary. So that's the intention. There's intentionality behind using Latinx. And I think it's a term that is widely used in some circles and some communities and not in others. And that is not necessarily universally embraced, and where there's also generational differences even within the Latinx community or Latino community for who is likely to use or embrace that term and who's not.
Okay. Another question I definitely do want to make sure we get to, and then also too, I'll open up if there's any specific questions, Carmela and Natasha, that you guys want to make sure we speak to before wrapping up, but comes from Susan Whitty, and she asks, of grave concern to me is the pending wave of evictions due to inability to pay rent nationally among individuals whose income and income generating capacity has been cut off due to the virus, and more generally among individuals with lower incomes. For these folks, sleep disparities may only worsen. What action should we be thinking about to shore up economic supports in the short run, locally and nationally?
Yeah, that's an excellent question. So thank you so much for raising that. I think the extent to which we can really be active and mobilize different communities and support those communities that are already mobilized around this issue, working with their local politicians, working at the state level, the federal level. I sort of rolled my eyes, forgive me for that when I said the federal level. Definitely at the local and state level is really key. In any collaboration that could be done with faith-based organizations. Faith-based organizations are so essential in vulnerable communities. They are known to step up and support resources, whether it's different food drives, housing resources as well. So I absolutely think that now is the time to work with all of these communities and continue to mobilize and support their action. But you're absolutely right. We definitely will start to see some of the impacts on this.
I realize that we're out of time. Tiffany, I see in scrolling through it that there are some questions about digital therapeutics and access to digital therapeutics. There's some employers that have, or I think some current trials where there's large employers that have included or worked with some of these digital therapeutic companies to provide them access to these treatments. From my knowledge, and that's actually one of the research grants that I'm leading, where there doesn't exist a digital therapeutic option in Spanish. That's actually what we're working on now, is to develop that and to test it in a randomized controlled trial. For those of you who are interested in specific Spanish resources, our team at Columbia created like a repository of mental health experts in the New York City metro area who provide services in Spanish. So that's a start, and we have that link in our PowerPoint here.
Maybe we want to go to the last slide, Carmela, that has
Oh,
our
sure.
information.
Yeah, good question.
Sort of,
Yeah, and so this is our contact information. Please feel free to contact us with any additional questions. I'm sure we'd be happy to do that. And let's see. Yeah, we'd be happy to do that. I don't know how much more leeway we have in terms of going over, Tiffany.
I'm pretty flexible. So if you guys want to, if you guys are available with your schedules, we can keep going for a few more of the questions for about another 10 minutes.
I could probably do one more or two more questions. How about you, Natasha? Yeah. I see here a question from Cheryl Tan about the sleep hygiene recommendations work well under normal circumstances for some people, but in the pandemic, my clients are finding these impossible. They're all working from home with multiple family members or roommates, so they often end up working in their bedroom. Even my most fit clients are not able to exercise adequately. Any thoughts about how to adapt? I think that's such an important question and point, Cheryl. And I think part of what I would say, you have to meet your client where they are. I think part of, I think what would be important is making sure that this conversation comes back and being able to do those functional assessments. And I like that Dr. Williams had mentioned in response to a related question about this earlier, to think about also how it's affecting potentially even work productivity, et cetera, and the sleep. So think holistically about that functional assessment, and then meeting, the same way people can't force themselves to sleep, you can't force a client to engage in certain behavioral change that they're not ready. But I think in terms of being able to assess what is working and what's not, or ways potentially to implement these practices or one of these practices in a gradual manner.
I just want to add very practically that one thing that I've been sort of reminding myself of is that, I can't be everything to everybody all the time. And so giving myself permission that every day is not going to be perfect as it relates to, structure and work and family. So I think really just being very practical about what is feasible given these circumstances, and that may change from day to day, and that's okay.
Some people are asking for the resource slide, so I'm just going to scroll to it. Natasha, is there any one of the questions that you'd want to make sure we get to?
There is a question about new moms and trying to sleep, and just, I remember they tell you this, if you have children in the hospital, all of the nursing staff say, go to sleep when your child goes to sleep. Mm-hmm. And yeah, sure, but it's absolutely true. That's what helps a lot. And just as much as you can have a routine, I think is really key. Those are just the things that I tried to practice when I was a new mom, and even with my children being somewhat older. It's the summer and we still have a routine, and they're not always happy with me, but I think it makes our household run a lot more smoothly.
Okay. And I just do want to let folks know that we will definitely be getting the copies of the slides out to you guys within the next week. That'll be getting posted. And then additionally, Natasha and Carmela, any recommendations for assessments for sleep health?
Yeah, absolutely. When folks say that, I'm not sure if, there's lots of different assessments that are used in sleep clinics for insomnia. There's assessments, and that I'm sort of thinking about the standard one, Natasha, that you're probably also thinking about. There's some, maybe Natasha, if like, the SATED metric or questionnaire is sort of publicly available. But I think the National Sleep Foundation might probably be the best place to go if you're looking for if you're looking for clinical measures, please, happy to, and even I think in behavioral sleep medicine that those might be posted, or you can contact any one of us. If you are interested in assessing your own sort of sleep or curious what kinds of measures could be included, you can also follow up with us. But there are standard and validated measures, both in English and in other languages, to assess for insomnia and other kinds of sleep complaints and sleep issues, and we'd be happy to share those.
Okay.
And I see, there's I think one important just, and maybe we can end here if there's another point, but I see someone asked a question about teletherapy sessions with client with significant sleep disturbances are conducted in her bedroom, on her bed, because only private place. Any suggestions? This issue comes up a lot, particularly when you think about New York City or urban living. And one, I think being able to create, even if it's a zone, what you don't want is for it necessarily to occur on the bed, but is there possible that it can occur at the foot of the bed or in a corner of the bed? Like, how can you create or isolate different aspects of your environment, of your room, which might be small, that can really just try to preserve the bed as the place where you're gonna sleep. And so that's the principle of that sleep hygiene tip or recommendation.
Mm-hmm. All right. Thank you, Natasha and Carmela, so much for your time and so much for this informative webinar.